This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds. We're going to go ahead and get started. This morning we have Dr. Christine Tompkins with us from University of Colorado. Dr. Tompkins is a faculty candidate for a position here in cardiac electrophysiology. She did her medical training at Georgetown and her fellowship and residency at Hopkins. She's currently, as I said, foreign associate professor, VP in medicine at EP at Colorado. She has a very interesting background and a lot of interest in sort of on the technical side on lead extraction, but also very interested, as you can see here, in the effects of sex on cardiac electrophysiology. And she's going to tell us a little bit about that today. So, Chris, welcome.
All right, well, good morning. And thanks for the opportunity to be here, and thank you for the invitation. So what I'd like to share this morning is what I've learned through my own research and the research of others about the effect that sex hormones can have on cardiac ion channel function and the electrical properties between men and women. I don't have any financial disclosures other than I'd like to recognize the Center for Women's Health Research, as they've been very supportive of the research that I've been doing. So what I hope you guys leave today with, again, is an understanding that sex hormones directly affect the ion channel function in cardiac ion channel function in particular. And we'll go through a little bit of that as well as some of the electrical properties that are affected. We'll discuss the clinical ramifications of the effects sex hormones have on the cardiac ion channel function. And then I'm going to switch gears a little bit, but use the previous two objectives sort of a background to talk about how sex differences in outcomes may be affected by the sex hormone modulation of key ion channels involved in ischemia and reperfusion injury. And that really relates to KATP, which has become my favorite cardiac ion channel, and of course the most important in the heart. So we've really known since the 1920s that electrical properties differ between men and women, right? Bizet reported that back then. It took a little bit of time before people looked into this further, so another 30 years or so passed before people recognized that the interval that really differs between men and women is the interval from the end of the QRS complex to the peak of the T wave. And just for a refresher, that correlates to phase 2 of the cardiac ion channel as well as phase 3. So phase 2, of course, is mediated by the L-type calcium current, and phase 3 by the delayed rectifier, and that'll have implications when as we go through this talk. But nonetheless, it really wasn't until the 1990s when the clinical ramifications of this became evident, and it was reported that women are at twofold greater risk of torsade de pointe when exposed to QT prolonging medications. Okay. So beginning at puberty, you can see a number of changes in the ECG. One is the PR, first of all, heart rate of men tends to be a little bit slower than women. PR interval is longer in men compared to women. The QRS amplitude and width increase, and again, that QT interval decreases. And what you notice with men is they have this J-point elevation, and there are some subtle changes in the T-wave morphology and a bunch of heart rate variability parameters that we won't get into. And if I were to ask people what they thought the reasons for this was, most people would actually say it's estrogen. And certainly estrogen can prolong the QT. But the biggest effect is actually testosterone. Testosterone shortens that S to peak T wave interval more so than estrogen prolongs. It's been known since the 1990s, when there was this initial interest in understanding the effects of sex hormones, that sex hormones affect cardiac ion channel function. And they do so in a relatively rapid fashion, and it seems as though it's affecting multiple ion channels. So as an example, I just used estrogen. Androgens affect cardiac ion channel function, as we'll see shortly. But a lot of it is the L-type calcium channel that is mediated in phase 2. You have some effect on IK1, which is the inward rectifying channel, sort of toward the tail end of phase 3, and then, of course, IKR and IKS, which are the delayed rectifier currents of phase 3. The problem with these early studies is that the doses that were necessary to mediate these effects were supraphysiologic. So when you look at women, perhaps at term pregnancy, women's estrogen levels will be in the nanomolar region, or range, excuse me, whereas the doses that were required in these cell cultures to mediate an effect were in the micromolar, so several thousand-fold higher concentration. And this sort of eluded investigators for a bit. Because we've always thought that sex hormones mediate their effect by going through the genomic pathway. And I think we're all familiar with this, where the sex steroid crosses the cell membrane, connects with its receptor, translocates into the nucleus, where it dimerizes and binds to the promoter region of the gene of interest. This process is important for sex hormone or sex steroid effects and signal pathways, but it takes time. And importantly, when you expose cell cultures to any of the estrogens or androgens, the effect is immediate. And if you expose these cells to things like RNA synthesis inhibitors or protein synthesis inhibitors, sex hormones still elicit their response. So it's clear that they're working intracellularly through a different signaling cascade, and it wasn't until the 2000s that people realized that there's this novel non-genomic pathway through which sex hormones, and we think, probably have their predominant mechanism of action. And this involves using second messenger systems. So the most important appears to be this phosphatidylinositol and eNOS pathway, and evidence for this being the predominant pathway, again, rapid effects, but also if you expose the cell cultures to nitric oxide scavengers or nitric oxide synthase inhibitors, the effects are reversed. So in the next couple of slides, hopefully aren't going to bore you too much, but just to give you an idea of the complexity of how sex hormones affect ion channel function and sort of the dose-dependent response, because I think this is something that's not traditionally introduced in training. But it's clear, so the group out of Japan did a ton of work looking both at estrogens and androgens, and we'll go through that separately. And I tried in each slide to give you an idea of the physiologic range, because finally exposing these cell cultures to a physiologic dose elicited the response that was observed. And so what you can see here is that when cells are exposed to low-dose estrogen, which is, and 17-beta estradiol is the predominant estrogen of premenopausal women, so that's the estradiol that's being used. But when it's exposed to, 1 nanomolar concentrations, which is what a woman would see during their menstrual cycle, the QT prolongs, which is all what we would all anticipate. But I think what would surprise most people in the audience is that if you use higher doses, and those that are present in the more term pregnancy range, so more on the nanomolar, 100 nanomolar level, the QT interval actually shortens. And it does so pretty rapidly. All of this is within a 20-minute time period for both effects, again, supporting a non-genomic pathway. Whoops, going the wrong way. When the investigators looked at the action potential profile to see where are these effects being elicited, what you can see is that most of the effects is occurring here in phase 3 of the action potential profile. So again, with controls, as you increase the dose of 17-beta estradiol, the action potential and hence the QT interval prolongs. However, at much higher doses, the action potential profile shortens. So the investigators then went on to look at the function of IKR and IKS to see how estrogen was mediating its effect. And what you see is really, what I think is pretty interesting, is that at low dose, 17-beta estradiol inhibits the function of the rapid component of the delayed rectifier. And that, of course, will prolong repolarization. It doesn't have any effect on the L-type calcium current or IKS until you get in the higher dose range, where you have maximal inhibition of IKR, but also inhibition of the L-type calcium current. That, of course, will shorten the plateau phase, and then that in combination with activation of IKS, the slow component of the delayed rectifier, brings about repolarization much more rapidly. When they looked at progesterone, they also found that progesterone itself in a dose-dependent fashion decreases the action potential profile, again in this phase 3 of the ion channel. Again, dose-dependent response and was dependent on the progesterone receptor. Progesterone, however, doesn't have any effect on the L-type calcium current, which you can sort of anticipate looking at the action potential profile. It's a little bit more complex than that. Again, at much higher doses, which you see during pregnancy, there seems to be an effect of progesterone on expression of the hERG channel. The mature glycosylated form is underexpressed when exposed to progesterone at increasing doses. So again, this is near-term pregnancy, probably through a genomic pathway of some sort, in that it is time dependent. You do not see these effects immediate. They take hours, peaking at 8 hours in duration. The effect on the IKR channel is, as one would anticipate, it inhibits the IKR. So again, progesterone at high doses looks to prolong the QT interval, but at low doses shorten the QT interval. And then finally, testosterone, known to shorten the QT interval, as I mentioned, at puberty. A number of those changes are observed. And again, you can see a much greater effect on the plateau phase in addition to the phase 3 action potential profile. And again, it's mediated at low dose by activation of IKS, so bringing about repolarization of phase 3 more quickly. Little effect on the L-type calcium current, but at higher doses, maximal activation of IKS and inhibition of the L-type calcium current. So in summary, for sex hormones, their effect on cardiac ion channels, again, not straightforward, not simply dose dependent. At high doses, you can often see opposing effects. So low dose estrogen will lengthen the QT interval and action potential through its effects through IKR, but at high doses will shorten the action potential by enhancing IKS and inhibiting the L-type calcium current. Progesterone, again, shortens QTC and action potential and does so by enhancing the slow component of the delayed rectifier, but it can increase the action potential profile at near-term concentrations of progesterone. And finally, testosterone is probably the most straightforward, where it's dose-dependent and shortens the QT interval at both low and high dose. So now moving on to the more fun stuff. So clinically, why is this relevant? Back in the 1990s, this is probably one of the first papers looking at the effect of sex hormones on the incidence of paroxysmal SVT. So they took a handful of women who were known PSVT and basically had them wear monitors on different intervals of their menstrual cycle. And what they found was that the luteal phase, which is just before menstruation, that the incidence of SVT episodes increased, that the number of symptomatic episodes increased. There was the episodes tended to be longer and have a slightly higher heart rate, a trend toward higher heart rates. There was also noted to be increased number of PVCs as well as complexity of PVCs. So for clinically, I always ask my female patients if there seems to be a cycling with their symptoms, and if there is, I time their EP studies just before menstruation. They also measured their sex hormone concentrations, and what you see is a direct linear correlation to progesterone levels in terms of the number of episodes and duration of episodes, and an inverse relationship to estrogen. Adding to it is probably the sympathetic system. So it's known that norepinephrine levels are expressed to greater extent or greater degree during the luteal phase, again, that just before menstruation. So again, with female patients, when you consider bringing them to the lab to do procedures, that's something to keep in mind. Yeah, it's pretty well known, too, that hereditary arrhythmias are influenced by age and sex, and this is probably best illustrated by the long QT syndrome. I won't go into ARVC and Brugada, but those are two pretty well-known hereditary arrhythmias that are affected. And so age and sex significantly alter risk for cardiac events. Males or boys before the age of 15 are at significantly higher risk for cardiac events than females of similar age. And what's interesting is that risk reverses right at the onset of puberty, where females carry a higher risk for cardiac events beginning at puberty into and through menopause compared to males of similar age. Event rates, again, markedly reduced, 52% in females that are under the age of 15, and then increases significantly in the premenopausal period. And then this was noted to be significant in long QT type 1, and subsequent studies actually show that long QT type 2 is similarly affected. The pregnant state obviously is a time where there's a significant amount of hormonal fluctuation, as well as elevated estrogen progesterone concentrations. And what's something to keep in mind is that the postpartum period, where hormone fluctuations are the greatest, is the greatest risk period. So 40-fold increased risk for cardiac events. The good news is beta blockers abrogate that risk. Obviously, anyone with long QT syndrome or acquired long QT syndrome certainly should be on beta blockers through the pregnant period and into the postpartum period. So now, with that sort of as a background, I'd like to switch to ischemic heart disease and how sex hormones may affect outcomes in that. So I'm sure everyone in this audience knows cardiovascular disease is the leading cause of death in both men and women. What I think is less known is that more women than men since 1984 have died of cardiovascular events. If you ask any female patient, they'll still tell you breast cancer, which drives us nuts, but nonetheless, you can see that in 2000, the risks or the rates of cardiovascular deaths declined. Obviously, this was due to our improvements in treatment, as well as increased awareness in the community. And for the first time ever in 2013, the risk of, or the rate of cardiovascular deaths in women dropped below that of men. This is another entity that appears to be influenced by age and sex, and this is actually from the 1990s, and I bring that up when I show you the data that we've, the studies that we've done. But what you see is that in the perimenopausal phase, or premenopausal phase, that women who suffer an acute myocardial infarction are at significantly elevated risk relative to the male counterparts of in-hospital mortality. And there's probably a lot of explanation for that, delayed presentation, there may be some treatment bias, whatever. But what I'm hoping you'll leave with is I think that there's a biological explanation as well, or contribution. Additional data that came out in 2000, using data from 2004-2007 from Zhang, showed that mortality for women in hospital mortality following acute myocardial infarction is higher for women of all ages, up to 80 if they suffer an ST elevation MI. Similarly, up to the age of 70 for an non-ST elevation MI. And these are using much larger data sets. That I should have mentioned, the first study was actually 385,000 patients, which in the 1990s was really big data at that point. But nonetheless, showing these trends where in-hospital mortality is higher for women. The group also showed that revascularization rates were lower for women, suggesting perhaps a treatment bias, both for PCI and CABG. The risk for ventricular tachycardia was lower in women than men, but the risk of VF was similar between the two, and cardiogenic shock is higher. It seems to be higher in women. And what you see, there's a signal here, at least, that VF and cardiogenic shock may be age dependent, meaning that younger women seem to be more at greater risk, although crosses unity, but at greater risk for VF or cardiogenic shock than certainly older women are. Okay, and I'm just setting the stage for what I'm going to talk about. And then the final study that I'll mention was published by Christine Albert, and she looked at the Nurses' Health Study cohort, who enrolled 120,000 women between the ages of 30 and 55. And they looked at, they identified patients who died suddenly within an hour of onset of symptoms, and identified 244 patients. And what's interesting is that, 2/3 didn't have a history of coronary artery disease, but almost all of them had at least one coronary artery risk factor, including diabetes, hypertension, or smoking. And what's important is that 88% of these were sudden deaths were thought to be primary arrhythmic, and 3/4 of them had documented VT-VF as the initial rhythm. So there seems to be something, and again, this age-dependent phenomenon where younger women seem to be at greater risk, perhaps for ventricular arrhythmias as a cause of sudden death. So we went ahead and looked at trends in in-hospital mortality following acute myocardial infarction using more recent data. So we were able to get de-identified, and I should mention that this has been submitted for publication but has not been accepted yet, We looked at or obtained de-identified hospital discharge records from 8 states. And again, this was inclusive of years 1997 to 2013, so a little bit more recent than the 2 prior studies that I shared. They all had a primary diagnosis of acute myocardial infarction. We ended up with a total of 3 million records. We excluded people who were under the age of 18 who we didn't have either sex or disposition data for. And so we ended up with a total of 2.3 million records, which is the largest cohort to date looking at this question. And again, we looked at the primary endpoint of in-hospital mortality. Busy slide, but basic baseline characteristics. We differentiated based on discharged alive or in-hospital death. And what we found, of course, not surprising, older people tended to die in hospital than younger folks, tended to be white, and if you had heart failure, your risk of in-hospital mortality was higher. We also found that the premenopausal phase was the greatest risk for in-hospital mortality. Again, women under the age of 50, twofold risk of in-hospital mortality compared to men of similar age. And I think what was most striking was that when I superimposed the study from 1995, nothing has changed. So if anything, things have gotten worse. This is our curve from our more recent data. So in-hospital mortality for premenopausal women still remains significantly higher than their male counterparts. And this is despite the American Heart Association's initiative to educate providers and educate the public about the risk of cardiovascular disease in women. We also looked at the risk of death based on type of MI, and again, the risk of in-hospital mortality is higher for women of all ages up to the age of 80. This graph is nearly identical to the one from early 2000. And then STEMI similarly, the risk of in-hospital mortality is elevated in women up to the age of 70. We looked at other factors that may have contributed. So clearly, in both men and women, if you had a STEMI, your risk of in-hospital mortality was significantly higher than if you had an NSTEMI. Complicated MI, not surprising, that was a composite of cardiogenic shock and cardiac arrest. That increased your in-hospital mortality markedly, both men and women. And importantly, there's still these trends of a perception, I'll say, because it hasn't been tested, of treatment bias, where regardless of whether a woman made it out of the hospital alive or died in hospital, they were referred for coronary angiography and intervention at lower rates than their male counterparts. So when we looked at multivariate predictors, again, an MI complicated by cardiogenic shock or cardiac arrest was the greatest risk factor, 17-fold increased risk of in-hospital mortality, not surprising. The next most important risk factor was being female, 3-fold increased risk of in-hospital mortality. That was a greater risk than having a STEMI and dying in hospital. Heart failure increased your risk by 50% of in-hospital mortality and peripheral vascular disease by 42%. When you look at sex-specific predictors of in-hospital mortality, again, complicated MI, greatest risk factor for both men and women. Similar odds ratio, 16.8 for men, 18.4 for women. Next important risk factors, of course, STEMI, about 2.2-fold. And then for men, heart failure increased your risk by 68%. Peripheral vascular disease slightly beat heart failure in women, increasing the risk of in-hospital mortality 44%. So hopefully by now I've convinced you, one, that sex hormones directly affect the cardiac ion channel function, and that influences susceptibility to arrhythmias clinically. That age and sex seem to influence outcomes following acute myocardial infarction. Women have a 3-fold increased risk of in-hospital mortality, and this sex difference in mortality appears to be greatest in the premenopausal phase. Younger women may, again, this is something that still needs to be investigated, have higher rates of cardiac arrest and cardiogenic shock. And so now I'd like to go on and share my interest in the K-ATP channel, which of course is the most important cardiac ion channel. So this is an octamer. It's composed of the KR6, 4 subunits of the KR6 and 4 subunits of the sulfonylurea receptor. So KR6 is an inwardly rectifying potassium channel. It also works through phase 3 of the action potential. And the sulfonylurea is actually a regulatory subunit. This ion channel, its primary purpose, we think, is to be cardioprotective in ischemia and hypoxia. It's expressed on the sarcolemmal cell membrane as well as the mitochondrial membrane. It's activated during ischemic states or hypoxic states, and when it's activated, it hyperpolarizes the cell membrane. And that has two consequences that are thought to be cardioprotective. One is it shortens the action potential profile because it brings about phase 3 more quickly. And it reduces intracellular calcium cycling, so helps avoid activating the apoptotic pathway. And again, this is thought to be cardioprotective. There's some argument about that because anyone in EP will also understand that if you have a regional hyperpolarization near areas of normal repolarization, you can get that can actually propagate or be proarrhythmic because of some of the electrical sync that occurs. So as I mentioned, KR6 is an inward rectifying channel. Two isoforms, both are expressed in the ventricle, and they confer the conductance properties of the ion channel. And then the sulfonylurea is part of the ATP binding cassette superfamily. There are four isoforms. SIR1, A and B are expressed in the atria and have been implicated in atrial arrhythmias, including atrial fibrillation. SIR2A and 2B is expressed in the ventricles and of interest. And this is what confers metabolic sensitivities. The KATP channel is obviously also very active in the pancreas and is involved in glucose management. So I should mention that it's triggered by low ATP, high ADP levels, as well as any changes in pH status. So alternative splicing of the subunits determines the composition and hence the properties of the channel. And again, KR 6.2 and SIR2A are the predominant configuration, although 6.1 and 2B are certainly observed, and 6.1 probably has plays more of a role in ischemia, as you'll see in a minute. Importantly, mice with mutated or reduced KATP, one have increased susceptibility to atrial and ventricular arrhythmias. What's also interesting is they have decreased exercise tolerance, about 50% of the wild-type mice, and they can develop fulminant heart failure and impaired calcium handling. If you look specifically, knocking out KR 6.2, it lacks ST elevations from ischemia. If you knock out 6.1 and SIR2A, you have spontaneous ST elevation and a marked increase risk for sudden death. And then the final property of the channel is that its composition or the subunit composition is dynamic and changes with time. So again, acute ischemia and the composition that's observed during acute ischemic states is very different than chronic ischemic states. So again, this is preliminary data. Basic science is a fun field. It's taken a long time just to generate this bit of data. We went about it in multiple ways, but part of the initial stuff is becoming familiar with the ion channel and proving that, doing validation studies and proving that we were able to detect each of the subunits, and working with Roger Bannister, who's one of our cellular electrophysiologists, in trying to do some patch clamping of the channel. And it's actually a very difficult channel to clamp. So we took young adult rats, this age, puberty in a rat is at about 1.5 months, so about 45 days, and menopause in rats is about 15 to 18 months. So these would be considered young adult, but sexually mature rats. We harvested ventricular myocytes and incubated them in normoxic and hypoxic conditions, so 1% oxygen for 24 hours, and then quantified the KATP subunit expression using RT-PCR and Western blots. And then, as I mentioned, we did some patch clamping. We exposed the cells both at, just looked at the baseline conductance, but then exposed it to pinacidil, which is a KATP channel opener. And at baseline, we didn't see significant gender differences in mRNA transcript levels. We did, however, see some changes in protein expression, and notably in KR 6.1, a trend towards 6.2, but really no significant difference in SIR2A or 2B. When we looked at the channel conductance properties, what we saw at baseline was that the conductance between male and female was similar. However, when exposed to pinacidil, the conductance and current density was higher in males compared to females, which is likely due to the increased expression of KR6.1. We then looked at the differences in hypoxic state, looking at the mRNA transcript levels. And again, to orient you, the solid bars are the controls, hatched are hypoxic, blue are males, red are females. So again, not a ton of difference, perhaps a little bit of noise in the overall expression of each of the subunits between males and females, either in the control or hypoxic state. However, again, with protein expression, one, you'll notice a general downregulation in the protein expression of most of the subunits, and then a significant difference mainly in KR6.1 and SIR2B expression in males and females. And so, to summarize these findings, we really didn't find significant sex differences in baseline or post-hypoxia mRNA transcript levels, but we did find significant difference in protein expression, particularly in 6.1, that seemed to affect the conductance properties of the ion channels between males and females. And so one of the obvious hypotheses that we have is that this may, to some degree, explain some of the differences in outcomes between men and women, particularly in premenopausal women. When exposed to hypoxia, the protein expression decreased significantly in both males and females, and there were subtle differences in the degree of expression between males and females based on gender. So I'm going to just stop there for a minute and just to get you to think about it. Any of the EPs in the room will tell you, one, women who receive defibrillators, particularly for ischemic heart disease, rarely have a shock. And when you think about it, how many VT ablations do we do in women who have ischemic heart disease? I can probably count on one hand compared to the hundreds I've done in men. And that contradicts what I've shared. So there seems to be something different between the acute ischemic phase and the chronic ischemic phase. And so one of the things that I did was I went back and looked at our MADIT. I was at the University of Rochester and had access to some of the data up there. And one of the things that we looked at was what was the risk of VTVF or death in men versus women who enrolled in MADIT-CRT. Just as a reminder, it enrolled just under 1,800 patients who had ischemic or non-ischemic cardiomyopathy, mild heart failure, QRS restoration of 130 milliseconds or more, and patients were enrolled 3 to 2, either due to CRT or ICD. And if you looked at the overall cohort, women were at significantly lower risk of VTVF or death, 38% lower than men. So again, different than acute myocardial ischemia. And if you look specifically at ischemic heart disease, again, keeping CRT and ICD together, even lower risk of death in women, 49% lower than men. So I then, how far can you parse data, right? So then I looked at ischemic heart disease who received an ICD only, exclude, women in MADIT-CRT were super responders to CRT, so was that, confounding the data. And what you see is that probability of VTVF or death significantly lower in ischemic heart disease in women who have an ICD only. And this was driven predominantly by VTVF. So it's clear in chronic ischemia, women are far less likely to have VTVF than men. So again, a little bit contrary to what we've been talking about. I can't tell you the answer, but my hypothesis is, or hope, is that K-ATP expression may be different in men and women in chronic ischemic heart disease, and that's sort of one of the things we're going to be looking at. But KR6.1 expression, so let me back up. This was a group that looked at K-ATP subunit expression at the infarct border zone. The white bars are controls, black are infarct models. This is an ischemia reperfusion injury model. And what you can see is that from day one, as we noted, there's a relative down expression, down regulation of KR6.2 and sulfonylurea 2 isomers. But as time goes on, there's increased expression of KR6.1, SIR2A, and SIR2B. This is not a gender study, but it would be interesting to see if there is a difference between men and women, and can that explain to some degree the differences that we observed in MADIT-CRT. And with that, I will end. So in conclusion, sex hormones clearly affect ion channel function, and that affects susceptibility to arrhythmias. Age and sex, as I mentioned, affects outcomes in ischemic heart disease. There appears to be a difference between acute ischemia and chronic ischemia, with women at increased risk of in-hospital mortality. And this may be multiple factors, including perhaps a biological factor. Women tend to present later. They have atypical symptoms, treatment differences in undergoing coronary angiography and reperfusion, but it also may be due to sex differences in potassium K-ATP channel expression and function. And then in chronic ischemia, it's clear that women are at far lower risk of VTVF or death, and this may and needs to be explored further be due to temporal differences in K-ATP channel expression. Thank you.
Okay, we have time for some questions. I'll start out with, so with the K-ATP channel, is there much known about sort of post-translational modifications that could explain some of the
There is
discrepancies?
some phosphorylation, absolutely, that occurs post-translation, and we had not looked at that. Yes, absolutely.
And then the other question I'll ask while people are getting ready is, in the unpublished cohort data you have from the 8 states, that sort of is an interesting time period from 97 to 13, and sort of a lot changed over that period. Have you looked at is it robust enough to look at sort of early and late difference and see if there's some temporal effects?
Absolutely, yeah, and we're certainly looking into that. We had the same question, yep.
Thanks for the talk. There was a very controversial statement submitted where they parsed data according to gender for all the primary prevention ICD trials, and women did not confer a mortality benefit. Does that, I mean, it's all post hoc. Do you, A, do you agree with it? B, do you alter your practice if in a woman versus a man as far as making that decision, who to put defibrillators?
Yeah, I think the key distinction is women do benefit from a defibrillator, meaning if a woman has a ventricular arrhythmia, it will save her life, right? The problem is our current selection criteria are not robust enough to identify those women that are at greater risk. So at this point, until we have better selection tools to identify those people, I don't think that we can differentiate or offer defibrillators to a lesser extent. There clearly is a mortality benefit to defibrillators in women. It's just that the incidence of arrhythmias is lower. So I don't change my practice. Yeah.
From my understanding, the effects of sex hormones on cardiac ion channels has been well established in the ventricular myocardium, but I don't know that there's as much research if there's differences affecting atrial electrophysiologic properties, and do you know of any data that would help understand differences in atrial fibrillation between men and women?
Yeah, you're right. It hasn't been explored as robustly. As I mentioned, the K-ATP SIR1 units are expressed in the atria, and there do seem to be sex differences in SIR1 expression.
Any other questions from the group? Okay, well with that, Crystal, thank you so much for a great talk. I really appreciate you taking the time.
The preceding program is copyrighted by Emory University.